with an interesting case presentation followed by discussion in each subspecialty of orthopedics. This season is dedicated to each subspecialty of orthopedics, surgeons having interest in each branch with the goal of uniting skill with mastery, where the presentation is being moderated by the expert in that particular field. This platform is not only aimed at the orthopedic surgeons to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. The program is conducted under the chairmanship of Dr. S.S. Mohanty and Secretary Dr. Ashish Phadnis, Dr. Mrinal Sharma, Dr. Swapnil, Keny, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SETGS Medical College and KM Hospital, Mumbai. He is an honorary consultant at Jaslok, Nanavati, and Susrisha Hospital. He is the past president of Bombay Orthopedic Society, an academician and a researcher. Today, we have three brilliant orthopedic surgeons, one each in arthroplasty, arthroscopy, and bone tumor, with an expert panel including Dr. Gaurav, Dr. Hitesh, and Dr. Anoop. I would now like to call upon Professor Mohanty sir to introduce our presenter and proceed with the session, giving a brief introduction to each of them as he is out of country today.
Thank you, Deepak. Good evening, dear friends. Greetings from Serbia. Actually, I am at Belgrade attending the SICOT Annual Orthopedic Congress, and thank you all the speakers and moderators for joining today. Today it is the 11th episode of the session 2 of Controversies and Consensus, and this episode has been dedicated to the arthroplasty, tumors, and the sports medicine or arthroscopy. And we have all the brilliant speakers who will be presenting and discussing. And as you know, Controversy and Consensus focuses on the topics on case-based discussions, followed by the discussion on the topic. And your participation is crucial. Whenever you want to ask a question, please put it on the chat box. And people from OrthoTV, Gaurav and Poonam, they are there, and they will just send it across to us for discussion. Now, without spending any time, let us start the show. And may I request Dr. Deepak to put the first slide for the arthroplasty session, correct?
Yes, sir. So, no, sir, this for arthroscopy session, this sports medicine, Dr. Karun has to join EC meeting there in Delhi. So, and Dr. Karun Jain, we don't need much more of introduction. He's a very, academic and a brilliant orthopedic surgeon in
Can
Delhi.
you make it full screen, please?
Yes, sir, it's full screen now.
No, you're seeing the, just click on that. All of you see the full screen? I don't think so.
Yeah?
No.
Yeah, go on, yeah.
Okay, but continue, no problem.
Yeah. Dr. Karun is an expert in trauma surgery, joint replacement, arthroscopy, sports medicine, and other orthopedic related disorders with more than 15 years of experience. His interest is in regenerative medicine, which has rewarded him with exceptional clinical work and research papers that he has presented in prestigious international and national conferences. He is awarded with Visishta Chikitsa Ratna Award by the State Medical Association, that is Delhi Medical Association, for his outstanding work in the field of orthopedics. His special interest is in orthobiologics, joint preservation, and sports medicine. So to moderate the session, we have expert Dr. Gaurav Sharma. He's an upper limb consultant at Sir H.L. Reliance Foundation Hospital, Mumbai.
Next slide, please. Next slide.
Assistant professor at MGM Medical College, Kamote. And he has done his fellowship in complex trauma and arthroplasty under Dr. Didi Tanna sir, fellowship in shoulder arthroplasty and arthroscopy under Dr. Sanjay Garude sir, and he has AOA accredited fellowship in complex shoulder and elbow surgery under Professor Des Boker from Sydney, Australia. He has more than 40 publications in peer-reviewed journals. Now, I would like to invite Dr. Karun Jain to present his case.
Good afternoon, good evening, everyone. So, am I audible?
Yeah.
Okay, you can share your screen, sir.
So can you see the full screen?
Not full screen.
There is a little lag. No issue.
Yeah, go down to the bottom corner. Yeah, yeah. That's the button. Perfect.
Now you can see.
Not yet.
There is some delay.
I think now you will be able to see.
Yeah, go ahead.
Yeah, good evening, everyone. So thank you, the panel, Dr. Mohanty sir and Dr. Deepak Gautam for inviting me for this interesting controversies and consensus in the orthobiologics and sports injuries and arthroscopy. So I will be presenting a very interesting topic, which is very common in sports medicine, that is rotator cuff tear. And we have analyzes the effect of growth factor concentrate augmentation along with GFC rotator cuff repair and what evidence we have got. So along with the case, we had made a case series, and we are happy that this case series is accepted for the publication also in a very nice peer reviewed journal. Soon it will get published. So as we all are aware, orthobiology, just to say a few words about orthobiology, is that it is not a magical entity. It is a procedure. There is no shakalaka boom boom. It has its own indication, contraindication, and limitation. Just like just to give a message to all the surgeons, whenever we have intra-articular fracture, we don't nail it, we plate it, because that intra-articular fracture is not an indication for nailing. Similarly, orthobiologics also have indications, limitations. If I have to talk about sports injuries, if there is a complete ACL tear, complete supraspinatus tear, and if we advocate this injection in that means we are misleading the treatment. This injection can be augmented along with the procedure, or if we have partial tear, then this injection can help in healing faster. So we have to choose the patient wisely, otherwise these procedures will bring the bad names to the surgeons. Orthobiologics is also not a new entity which we think this nowadays. We all remember doing bone grafting for non-union, iliac bone grafting. And what is it? That is nothing but bone scaffold soaked in bone marrow. So orthobiologics is an age-old technique, but coming to us in a different shape and size. And just to give the audience the size of this orthobiologics emergence, it is estimated by 2030, orthobiologics, it will be a bigger market than arthroplasty and scopy in Western world. So, which we all are aware, there are four different varieties of procedures are there in orthobiologics. One is blood related, that is PRP, GFC, and other preparation. Second is BMAC, bone marrow derivative, then fat cell derivative, and fourth one are the new entities which are not available as of now in India: exosomes, placental derivatives, legal point of view, umbilical cord derivatives. So there are so many athletes who have undergone orthobiological treatment in one way or other. Tiger Woods, Kobe Bryant, Mara Sharapova. If you Google it, there are almost 100 plus top-notch athletes who have taken the treatment. If we count our Indian athletes have taken, so many cricketers have taken orthobiologics treatment one way or another way. So coming to the indications, there are good amount of indications are there, like adhesive capsulitis, fracture non-union. We are lucky to, this special issue of IGO is coming up, and this article is coming up on fracture non-union use of GFC injections. Tennis elbow, golfer's elbow, partial meniscal injuries. As we all are aware that meniscus injury have very limited or no blood supply. So these injections are coming up as a promising treatment for meniscal injuries, partial tendon injuries, Achilles tendonitis, and adjuvant to tendon repair surgeries. And our today's talk will be adjuvant to RCR treatment and osteoarthritis knee. So coming to rotator cuff tear, being it is a very commonest pathology of shoulder, still there is a wide treatment options are available for the treatment, and the aim of the surgeon is to achieve a pain-free shoulder with a good range of motion. So whenever we talk about RCR, most of the jury will agree on that. The two most common problem which we face is re-tear rate. There are good amount of journals which quote re-tear varies from 13% up to 94%, and satisfactory outcome, that is pain and range of motion. So this require a lateral thinking. Can we do something with our conventional RCR? So with that thought, we have started augmenting our all RCR cases with GFC injection. GFC is nothing but growth factor concentrate. Don't go with the market driven word of the GFC. GFC is nothing but a activated form of PRP. So if you have PRP and you activate it outside, that becomes GFC. There are lot of wordings, nomenclature, patency coming up nowadays because all industry is entering into it. But baseline GFC is activated PRP. So I have already told that we have started doing this research. So our study design was inclusion criteria wherever we had a repairable full thickness tear of the rotator cuff. Patient is willing to get randomized for the treatment with or without GFC. Patient have adequate resources to get a MRI done. For exclusion criteria, we had fracture of the shoulder, instability, cuff joint arthropathy, because those cases most of the times become eligible for plasty rather than scopy. Extension of the tear to subscap or isolated subscap tear, degenerative arthritis, glenohumeral or AC joint. If we have irreparable tear, because nowadays for irreparable tear we have started getting the commercially patches and latissimus dorsi patches. That is a altogether different topic, so we will go in detail of that. And a patient had a previous surgery of the same shoulder. We had a long list of exclusion criteria because our study was first of its kind, and as far as my knowledge is concerned, nobody has published in India this kind of study. So we had done an extensive exclusion criteria. So this is a standard double row repair which we had done. This is standard all arthroscopic procedures, double row and lateral row. So coming to the injection. So first injection, what we have given after RCR repair, it is done by spinal needle, which was inserted approximately 1.5 centimeter anterior to the lateral wall and 15-degree angle. So idea of that needle, when we are seeing by the arthroscope, that the injection goes underneath the repair. Even though what we have learned by doing this study, by reading the literature, that you require a good amount, around 6 ml, so that the entire joint get filled. But a recent advancement, which we have started doing it, we have started giving GFC in a fibrin point, like we have the PGF, no, platelet rich fibrin. So similarly, so that we can get a gel form and get inserted directly underneath the patch. So that is the advancement which we have started doing it. But as of now, in this study, we had given a simple GFC injection. First injection was given under the arthroscope, and second and third injection was given after 15 days and 30 days without any arthroscope in OPD basis after making the injection. Outcome was measured pre-operatively and post-operatively, 1, 3, 6 month and 12 month. The primary outcome measure was standard disability of arm, shoulder and hand score, that's called DASH score. Secondary outcome measure was constant score, active forward flexion, external rotation, internal rotation, and VAS score. Fatty degeneration was also documented. MRI was performed 3, 6, and 12 month. All patients completed DASH and VAS score independently without any assistance, so that bias is not there. So before we go in deep detail of studies, a simple briefing point about GFC. I have told earlier also, GFC is nothing but activated form of PRP, which has usually platelet more than 2 to 7 times of normal blood concentration, and a concentrated mix of growth factor, cytokinin, which are naturally occurring protein that stimulate cell growth and division, promote angiogenesis, accelerate new tissue formation, is the basis of GFC injection. It is a minimally invasive and does not have major side effect and a affordable procedure. Mind you, the cost of RCR, and if fails, the cost of revision RCR or the cost of revision arthroplasty is more than 100 times with this simple injection. So why not to give? Since we have some time, so we can, the procedure of making PRP is similar making of GFC. What we use, we don't use any commercially driven system. We use a very simple standard dual spin technique. What is dual spin technique? First is slow spin, 900 RPM. Then you shift the PRP. If I have slide, yeah. So second spin, you shift the supernatant plasma and buffy coat in the simple tube and go for the hard spin. And after the hard spin, you take the lower part. This is very simple, which anybody can understand. Dual spin, पहले में हल्की स्पीड से, दूसरे में तेज स्पीड से, पहले में ऊपर वाला लिया, दूसरे में नीचे वाला लिया. Simple, low cost. You don't require a huge setup for this. Only simple, like any injection intraarticular, you need to maintain a good hygiene. One point which I want to address: if you want to give any injection, one needle, one prick. One needle, one prick. एक यदि निडल से आपने एक बोतल में लिया, उसे डिस्कार्ड करना है, देन दूसरे निडल से दूसरे में, और जब आप इंजेक्शन लगा रहे हो तो बिल्कुल फ्रेश निडल चाहिए. मे बी 4 से 5 सिरिंज यूज होंगी, दैट विल कॉस्ट हार्डली 50 रुपीज, बट चांसेस ऑफ गेटिंग एनी इंट्राआर्टिकुलर इन्फेक्शन reduces dramatically. One needle, one injection, anywhere. So coming to our study, statistical analysis, standard technique was used by our statistician. So coming to the result, in group 1, RCR, 10 patients were there, mean age was 57. In second group, where RCR was augmented with GFC, again 10 subjects, 5 male, 5 women. And dominant shoulder was there in 6 subjects in that. Mean follow was 15 months. Now actually it become 18 months, but when we made it, it was 15 months. No infection, neurovascular complication, anchor pullout was noticed. So this is a very interesting slide. When we see group 1 and group 2, we can see that group 2 outshadowed group 1 in almost all the parameters. Internal rotation also had a good outcome, even though it was not statistically significant, but still had a good outcome as compared to group 1, especially VAS score. VAS score recovery was commendable. So as I told you, all these scores, especially constant score, dash scores, improved statistically significant. MRI assessment was done after 12 months also, and which reveals, interestingly, out of 10 subjects, 3 subjects had re-tear rate in group 1, and there was no re-tear rate in group 2. Out of 3 subjects in group 1, one patient had severe symptoms and underwent revision surgery. So coming to the case example, this is a group 2 65-year-old male, which had a classical rotator cuff tear, and after 3 months, the left hand slide you can see, and after 12 months, you can see footprint is fully covered, and this is his range of motion after the 12 month. Near total, a very satisfied old 58-year-old man. Second, a 55-year-old woman, group 2, as you can see, the supraspinatus tendon tear and type 2 pattern, and at the end of 12 months, again, the footprint was totally covered. This is her range of motion at the end of 12 months. This is the third case, a 49-year-old man, which had category 2 GFC augmented treatment. At the end of 3 months, supraspinal tendon was 50% of the normal footprint. You can make out in the left hand side image. And at the end of 12 months, again, very good, nice recovery. And this is the range of motion of this third man. So what have we achieved by doing this? Our study indicate that significant high rate of tendon healing is there, which does not require any special technique also. Overall range of motion improved as compared to without GFC injection. So while doing the study, we tried to find the evidence, because our world want good amount of evidence. So we went to multiple articles. I will quote few articles. This is one of the first article 2013, where they had done RCT, level 1 evidence. They had used PRP. And what they said the application of PRP for large to massive rotator cuff significantly improved the structural outcome, as evident by decreased re-tear rate and increased surface area of the supraspinatus as compared without GFC or PRP injection. This is again second study, American Journal of Sports Medicine, one of the most renowned journal, 2015 RCT level 1 evidence. Advocate the similar findings. Again, one more study, 2016, 12-month follow-up, double row repair with PRP shows a same result, good outcome. So this particular study, I want to fetch the attention of the audience. This study was published in 2022, recently. This is systemic review of level 1 to level 3 studies. And interestingly, we always say that sample size sufficient nahi tha, sample size chota tha. This study has a sample size of 1800 subject. It's a big sample size. 13 meta-analyses were included in this study. And what they concluded? They also concluded that in total, PRP bar GFC bar any blood protector you gave the PGF, whatever you want to say, is effective in reducing the re-tear rates after rotator cuff repair and improvement of functional outcome and reducing pain outcome, short-term pain outcome. So now one point when we say about controversies of PRP, we always say कि यार मेरे से रिजल्ट नहीं आता, पता नहीं तुम्हारा कैसे आ रहा है. This is the biggest problem. The problem is, as a surgeon, we don't accept it as a procedure. See, if I do a nailing, if I do a THR, if I do a knee replacement, I will not leave it at my assistant. I will do by myself. I will see the fine steps of the procedure. But when it comes to injection, हम बोलते हैं वो लैब का टेक्नीशियन प्रिपेयर करेगा, मेरे को बस डालने का है. So that is a very bad approach. If you are doing it, make it by yourself. Then you will get results. Second, if I have quoted good amount of studies which are in favor of this injection, then there are good amount of studies which are not in favor of this injection, right? So what is happening, as the years are passing, as the techniques are improving, the quality of PRP and GFC is improving. The first positive article came in around 12, 13. After that, the articles are improving. Why? Maybe the reason, because there is a potential improvement in technology. There is a good amount of patients who are getting this injection. See, if I talk about arthroscopy, in 1980s, when everybody was a trauma surgeon, there was no arthroscopy, famous arthroscopy, 80s. So it was something like a bundle of mystery that ye kya hai yaar, arthroscopy ye kaise hoegi. And this recently, in around early 2000, when we are started taking PL graft for ACL, that time there was so much of issues कि PL जाएगा तो चलेगा कैसे, कितनी strength रहेगी. But now, as the time is passing, we are realizing that PL graft is equally good, because now the sample size is big. So as the years are passing, the sample size is increasing, so the evidence are coming more and more clear. We still require a good amount of RCTs to claim what we are telling is 100% foolproof. But still, if there is no major side effect, if there is no major cost involved, if there is no much time involved, and if we are not taking away our conventional surgery, then why not to give it? Because at least it will have a good early pain outcome, and it will reduces the re-tear rate, which will in turn leave the less burden, financial burden to the society also. Thank you. And I would like to welcome you all for our DuaCon, that is 2020-24 in November. So those who want to join, please come. It will be a pure academic extravaganza for all of you. Thank you, everyone.
Thank you, Dr. Karun. It was a very interesting and convincing talk. You must be a good teacher somewhere. The way you explained, I think none of can be a good doctor for the patient to explain in such a way. You can convince anyone. That's for my words. You can convince.
Thank you, Dr. Deepak,
Now,
for
off
kind
to
words.
Dr. Gaurav Sharma.
Hi, all. Good evening. Wonderful, Dr. Karun. I would like to congratulate you for this particular study. It's really interesting. Definitely, PRP has a wonderful role. Just few things what I wanted to ask. I understand that being randomized, even 10-10 is a good kind of sample size. Did you observe or any correlation between any patients who had any comorbidities like diabetes or hypothyroid for that instance? Because
Yeah, actually, you are right. When we have a immunosuppressive disease,
yeah,
let it be diabetes or thyroid or hypertension, so the quality of PRP or GFC get reduced.
yeah,
To overcome that, as compared to the Western world literature, we have not given one shot, we had given 3 shots. Because whatever evidence I have shown, they had given one shot only at the time of surgery,
yep,
and they have made it either an injection or a gel form.
yep.
Recently, I have listened to a professor from Singapore. They are making gel form and giving single injection. So because your point was valid, and one of my co-author was not very convinced when a patient comes to your OPD and a high diabetes, maybe 300, 250. So the quality of cells will get reduced, even though we have done the growth factor analysis also. But still, 3 injections can overcome what you said.
All right. And in all your cases, you followed everything exactly the same. That is, all patients underwent double row repair, I presume.
Yes, double row repair also and single row also. Those
Okay.
who are single row also we have taken. But
Okay.
double row cases are actually the classical cases where this injection has a role, because double row that is a weak. That is why we are doing double row.
Yeah, exactly. Okay. And all, in terms of repair techniques, do you tie your medial row in cases of double row repair or
See,
something
at
like
times
that?
when we have the poor bone stock or poor tendon, so we go the lateral repair also, lateral row. So
Okay.
otherwise, standard conventional technique, there is no separate conventional technique as we are doing, as everybody is doing. The only thing is that we are adding GFC to
Yeah.
the simple treatment.
Okay. All right. And did you aim for some leukocyte-rich PRP or?
Well, see, I'll tell you, leukocyte rich and leukocyte poor.
Poor? Yeah.
There are 2 varieties of orthopedic illnesses.
Yeah.
There is cold orthopedics, what we say, that is osteoarthritis knee.
Yeah.
There is a role of leukocyte poor PRP,
Exactly.
because you don't want to inflate, have the inflammatory cascade.
Yeah.
But here in shoulder, you require leukocyte rich PRP.
Rich PRP. Yeah. That's right.
Because you want to inflammation to come. See, not everybody understand that PRP and steroids have a opposite spectrum. PRP is a pro-inflammatory, and why? With the pro-inflammation, it helps the healing procedure. So we use leukocyte-rich PRP, sir.
Okay, so did you find any difference in preparation for the leukocyte rich? Because it is actually very difficult. There are a lot of papers mentioning
No,
about.
don't get confused. I'll give you 2 minutes.
Yes, please.
See the slide which I had shown initially, the chart. So
The Buffy coat and the PRP, yeah.
Yeah, so first is supernatant plasma.
Yeah.
Then is a Buffy coat.
Yeah.
So if you take Buffy coat along with supernatant plasma, so what you will get is leukocyte rich PRP.
Rich PRP.
And if you leave the Buffy coat and take only supernatant plasma, So after second spin, what we will get is leukocyte poor PRP. So the game is by Buffy coat. Buffy coat लिया तो rich, नहीं लिया तो poor. Simple. छोड़ दिया poor हो गए, ले लिया rich हो गए. Simple way to remember.
Okay. All right.
Great.
Thank you for this particular.
I love this presentation. I love this presentation. The
really
way
good.
it convinced to all of us.
Yeah.
Okay. Thank you,
Thank
Dr.
you.
Karun. You may.
And if you
will be
kindly
logged in.
permit, I will leave for my meeting.
Okay.
So
Okay.
thank
Yeah,
you, Dr.
definitely.
Lovely to
Deepak,
have
Dr.
you.
Mohanty sir,
Here
Dr.
online.
Gaurav, Dr. Shivendra, Dr. Anoop. Nice interaction with all of you. Thank you, dear. Okay. Namaskar.
Okay. So now we'll go to the ortho-onco session. We have none other than Dr. Haresh sir. The ortho-onco part has never, disappointed us because every time they have come up with a case with good information. Dr. Haresh, no introduction needed. He has more than 30 years of experience in ortho-oncology. He's an innovator and first applicator of numerous hip, knee, and elbow megaprosthesis after tumor resection. He's awardee of numerous national and international fellowships and scholarships. Currently, he's the medical director of Anmol Orthovision and Orthopedic Cancer in Eye Hospital in Mulund, Mumbai. And he's a visiting consultant to Justwork and Fortis Hospital. Without spending any time, I would like to invite Dr. Haresh sir to present his case and give us a new message regarding the ortho-oncology, sir. Up to you.
So are you not going to introduce Dr. Hitesh Dawar?
Yeah, sir. Dr. Hitesh is there to to just add and augment you, sir. Okay, to augment you, sir. Dr. Hitesh Dawar is a leading orthopedic oncosurgeon and complex joint reconstruction specialist at Apollo Group of Hospital and is currently working in Apollo Delhi. He has numerous fellowships in ortho-oncology. And yes, Dr. Haresh sir, because of the time, I'd like you to go with the case and then we'll have a discussion followed with Dr. Hitesh, sir.
Okay. So
Okay.
can you allow me to share the screen?
Sure, sir. I'll just stop sharing and then you'll go ahead, sir. Okay, sir.
Is everything visible, full screen mode?
Yes, sir.
Yeah. So today I'm going to discuss a little controversial topic, which is what do you do when you have a sarcoma or a tumor which is occupying the entire length of the long bone? It's a very challenging and daunting task. If you see some slides here, you will see this osteosarcoma on the right femur of a young girl, which is extending from the fascial area of the distal femur right up to the area which is within about around 3 centimeters from the proximal fascial area. So, and circumferentially it is involving the entire thigh area. Then you have tumors like the giant cell tumor occupying the entire metacarpal bone or the phalangeal bone. So, what do we do when we have such patients is what we are going to discuss through some cases today. So, before we go to the case part and discuss a little what is happening with the patients, what is important for us to understand is that what are the challenges in this entire gamut of patients. The challenge is to get a safe resection margin. As we all know, getting a good resection margin is primary important so that we don't have local recurrences and we have a kind of a disease-free survival for a longer and longer period of time. We have to focus on the viability of the limb as far as the vascularity and the neurology is concerned. We should be having a good soft tissue cover because if you have something which you're reconstructing, which is right under the skin, the chances of it getting infected and having long-term problems will increase. Then you need good soft tissue anchorage so that you can get good function. And then, as every patient would want, the patient would want longer and longer time for the reconstruct to last. From the point of view of motivating and selecting a patient, you need to have a patient who has got a very high motivation level. He or she needs to understand that there are going to be setbacks during the course of treatment. And sometimes the setbacks could be so severe that despite doing a very nice heroic surgery to begin with, a couple of months or maybe a year or 2 years down the line, you might still have to go ahead and do an ablative surgery. This ablative surgery can also be a scenario when you have a lesion which has grown considerably between the last scan and the surgery, and then on table you realize that saving this limb is not any good, and you might have to just go ahead and do a limb ablative surgery. The reconstructed methods are very varied. You can use metallic implants, which basically essentially consist of a long segment of the bone along with two joints. We can create some innovations into our own implant, like this implant, which we are going to show you in the cases subsequently, has got an area where we can change the neck of the femur, the head of the femur can be changed, the trochanteric component can be changed, the turnkey bar, which is used to lengthen the processes, also can be changed. And so we can change various components of this processes as the patient keeps growing. Or we can use 3D implants now, 3D printed implants now. Other methods are natural uses of bone bank, tissue bank allografts, and sometimes we use composite processes and a graft reconstruct. So coming to our first case, Dr. Deepak, you can stop me at any point of time if you want, because this might, this thing, what do you call?
No, sir, you go on, sir. Go on.
Yeah. So, sorry. So this is the first case that we are presenting, which was shown in the slides also. This is the case of a 9-year-old female who's got an osteosarcoma of the right femur bone. As you can see from the X-ray, that the tumor is quite large. It is extending from the distal physis right up to the mid shaft or mid shaft of the femur. On MRI, this distance is further extrapolated, and we can see that from the tip of the GT, including the physis of the GT, the lesion is about 9 centimeters or 9.8 centimeters. There's hardly 10 centimeters of lesion there. And if you take away the fascial part of the GT, you have hardly any bone left to reconstruct. People who are indulging into reconstructions will appreciate that we need segments of at least 12 to 15 centimeters of bone so that we can have an effective, stable reconstruct for a longer period of time. In the transverse section also, we can see that the tumor is quite huge. The central part of the bone is there, and then the entire thing is a tumor. All muscles are kind of flattened and pushed to the side. And the neurovascular bundle, although free, is really, really very close. You can really appreciate that there is a kind of a good plane between the tumor and the neurovascular bundle. We did the counseling of this patient with the parents. We told them about the option of doing an amputation. They were not willing for that. We also gave them an offer of rotation plasty. They were not willing for that. So the option that we were left with is a modular growing processes where we, as I showed you in the previous slide, that there were different parts which we could kind of, go ahead and kind of change as the child was growing. So we designed these processes. We talked to our processes designer, and we took some time to design the various areas where we could change the processes, like the femoral neck, the femoral head, the trochanteric piece, the lengthening piece, then the distal fascial piece, the distal femoral piece also could have been changed as and when needed. We went ahead, we did a resection of the entire femur. This you can see here is the distal, is the proximal end of the tibia. Over here you can see the patella. Can you see the pointer on the slides? Dr. Deepak?
Yes, sir, we can see,
Yeah.
sir.
And in this area, you have the entire hip joint over there. Then this was reconstructed with the help of a modular growing processes. The process was put in place, and we could kind of get a good attachment of the abductors to the processes. So we did not have to use a mesh to reconstruct the hip joint. This is how the post-operative appearance of the patient was. And this is just to show you that the entire femur is been resected and it is comparable to the metallic processes. Now you'll really appreciate that over here the processes is about 1.5 centimeters longer than the parent femur bone. And this was this is, as you can see again here, the right leg of the patient is little longer than the left leg, because initially when we do the surgery, we have a margin of about 1.5 to 2 centimeters of lengthening. So that avoids one surgery for the lengthening procedure. So the first lengthening procedure in such patients will come up really after about like 9 or 12 months of follow-up. And this is how the patient was walking in the post-op period and was comfortable. She had no neurovascular deficit, and she did well after surgery. A second case, a 13-year-old female with a left entire humerus osteosarcoma. This is how the specimen looked after resection. After the resection, this is a bed where the specimen was removed from. This is the glenoid. Over here is the elbow joint. You can see the radial nerve over here. As I was saying in my introductory slides, that we need to figure out how we can retain the vascularity and the neurological structures. So this is the belly of the biceps with the musculocutaneous nerve on the underbelly of the biceps. Now, when we have a good biceps, we will have good elbow function. Now this is the radial nerve. This is the vascular bundle. Along with the vascular bundle, we have the median nerve and the ulnar nerve. Now when we do such kind of surgeries, there will be no movement at the shoulder joint, but there will be good movement at the elbow joint and complete movement at the hand and the wrist complex. So every time we are doing a surgery for the upper limb, we don't really get good movement in the shoulder, but the basic function of the shoulder is to put the hand in a spatial orientation so that the hand can do the function. The elbow and the shoulder joints really work as a supporting joint for the hand to function. If you really go and analyze, like even when you're playing a badminton or something, it is the hand which is using the racket, or the hand which is throwing the ball in the cricket, the hand which is writing on the blackboard or whatever. The shoulder joint and the elbow joint are just kind of structures to put the hand in a spatial orientation so that the hand and the wrist can do the function. So in this particular case, the shoulder does not have any function, but the patient has a good function at the elbow and at the hand wrist complex. So this is how the processes were designed. This was the simple processes because in the upper limb we don't really have to have a worry about the limb length discrepancies. And this is how the processes looked in the bed, in the resection bed. And this is the post-operative X-ray showing how the entire humerus has been replaced with shoulder and the elbow. Now between the two cases, what is the difference? In case one, you have a lower end, the bone of the lower extremity, which is the weight-bearing extremity. So you need to focus on the length all the time because, if you have a length discrepancy, then you will have to kind of look at the other methods of kind of doing growth arrest on the opposite side or doing some lengthening procedures, which is not the case in the upper extremity because upper extremity is not a weight-bearing extremity. Cosmetically, it might look little bad that one hand or one upper limb is shorter than the second upper limb. But generally, over a period of time, with the kind of disease that the patients are having, this is a very small compromise to accept. So limb length is very important in lower limbs. The modification, that is why, is very important for lower limbs. And the upper limbs, we can use off-the-shelf implants routinely. Because there's a weight bearing in the lower limb, there's more wear and tear of the lower limb implants. In upper limb, there is less wear and tear, so the longevity of procedures are better. And because of the dynamics of the lower limb, the rate of loosening in osseous axis is more. Therefore, one should always consider natural options like doing rotation plasty if possible in lower limbs. The parallel of rotation plasty in upper limb is doing a focomelia type shortening surgery. People don't really opt for it because it's not really such a bad cosmetic thing to have a one short upper limb and a one normal looking upper limb. But in lower limb, yes, longevity of the implant is very important. And hence we need to kind of really, really discuss other options with the patient as to which are more stable biologically and, from the orthopedic point of view, mechanically. Coming to the third case, this is a patient who was a 30-year-old male patient. In the first episode, this patient had a fall while he was removing some stuff from the shelf over the cupboard. He fell down from the stool and he sustained a subtrochanteric fracture. Now, technically, for a 30-year-old rough and tough male patient, falling from a stool should not lead to a subtrochanteric fracture. But he did end up with a subtrochanteric fracture. And he was taken to a hospital. This patient has come from abroad and he was treated with open nailing. You can see the X-ray that there is an open nailing there. Now the surgeon was good enough to assess that there is something abnormal with the marrow. So he took the marrow at the time of the nailing and sent it to histopath, which turned out to be chondrosarcoma grade 2. Now the surgeon over there told him that he should undergo an amputation. Patient was not willing for amputation. So he was referred to Mumbai. He had to arrange for his passport, visa and everything, which took about 3-4 months of time. And finally managed to come to India by flight, and then I was taking a train to Bombay. And while coming down from the train, alighting from the train in Bombay, he again had a trivial fall and he sustained a fracture of the neck of the femur. So now he has got a double problem. He's got a fracture of the subtrochanteric area which is not united. There's implant in the C2, and of course implant is not doing well, as we can all see. And there is a second fracture, which is fracture of the neck of the femur. Again, he came to us. We started off with the fact that, chondrosarcoma grade 2, it can be becoming a dedifferentiated chondrosarcoma, which should have a more aggressive kind of a course in his body, and it will be not really very having a good prognosis also. And it is better to do an amputation rather than doing a limb salvage. Patient was not willing, and then we started doing investigations to save the limb. The MR was showing that there is a disease and along the entire canal of the femur. And we counseled the patient. We discussed about the implants and other things, and then we planned for surgery. Now, as you can see here, I was talking about soft tissue covers and other things, right? So now, technically, if I have a virgin case, I would be operating in this dotted line, you know. I mean, people who do tumor surgery know that this is the classical approach for doing a total femur or a proximal femur surgery. Now, this patient has been nailed. Now, there is contamination in the scar, and there is contamination at the distal locking site, and there is a fracture and there's soft tissue all around. So, getting all that contaminated tissue out was also a challenge, and retaining the neurovascular bundle. Nevertheless, we went in, we did what had to be done, and we did the resection. We were lucky to get a good margin over there. You can see here in the resection bed, this is the hip area, and this is the femoral vessels. And you can see the sciatic nerve over here, which is intact and kind of going along all the down, the patella. And we could get a good amount of corticeps. Of course, there was some loss of the abductors in the hip area because of the contamination which had to go out. But we could get a good R0 resection. The margins on histopath were negative. This is how the resected specimen looked. The all contamination tissue along with the nail inside. You can see over here that there is bulging of the disease at the distal locking, the fracture side and the distal locking sides. This is the proximal cut end of the tibia. This is the head of the femur. So this is how the entire specimen looked. We compare it with the total femur processes that we are going to put. This is the trial processes. On the right side, you can see that the final implant has been put in place, and we could get good closure. We could close the incision nicely after having taken the extended incision that we took along the previous scar. And this is how the postoperative X-ray looks. The knee joint line is maintained, the hip joint line is maintained. There's no limb length discrepancy, and as you can see from the movement slides, there is no extensor lag. This patient has finished about 18 months of follow-up now and is doing quite well. So, after these three cases, what we need to discuss is about when somebody is dealing with such large tumors, what are the things that are important? Important is to have the neurovascular structures intact, and then we need to also have good soft tissue attachment so that the patient can have good function. Now, what are the ways to attach the soft tissue? In the normal body, the muscle is attached to the periosteum. Now, the periosteum is gone because the tumor is a sarcoma, and the muscle has no periosteum to attach. So we have tried things in the past like using a Prolene mesh on the processes and then attaching the muscle on the Prolene mesh, or making a kind of a lattice with muscling tapes and then attaching the muscles to the lattice of the muscling tapes. However, my experience over the last 3 decades with Prolene mesh and muscling tapes has been little poor, because we observed that the Prolene mesh and the muscling tapes continue to develop fibrosis till as much as 7 years in the postoperative period. And over a period of time, there's a lot of soft tissue tension and a lot of contractures and loss of movement, which was initially very good. You start developing loss of movement. And then, you have those muscle related issues like tears of the muscle and pain in the muscle and non-specific pain, little late into the presentation and follow up after 5, maybe 7 years. Of late, there are synthetic trivia tubes which are available. Now, these glide very nicely on the implant and they can be used effectively to anchor the muscle. But in my practice, what I do is I rely more on the intercompartmental closure. Like in all the cases that you saw, all the 3 cases, I had a volar or a flexor compartment, and I had a dorsal or an extensor compartment. So what I do is I just close the muscles lightly. I let the biofilm or the masculine membrane take over, form a nice biofilm on the implant which glides freely on the implant. And over the last about a decade or so, I have not used any artificial substances to cover the processes so that I can attach the muscles to it. I make sure that I get a good intercompartmental closure. So like in the case of the chondrosarcoma patient, we could close the corticeps to the IT band and the hamstring complex posteriorly. In the humerus patient, we could close the biceps. As you saw, the biceps was having the musculocutaneous nerve on the underbelly. We could close the biceps with the triceps fascia. And then once you close the fascia, the muscle with loose sutures, we can close the fascia so that there is no tension on the suture line, and the healing progresses nicely. So, that is at the end of the 3 cases. I would like to just share some take-home messages that I have developed over the last so many years of practice. when we see such large patients, an obvious choice is to do an amputation. But in today's modern world, although it might sound controversial, it might sound that we might not get a good margin and stuff like that. But we have to understand that we have to evaluate each patient irrespective of the size and the extent of the tumor. The patient should be chosen very well. The patient should have a high level of motivation. The pathological fractures that patients have should be salvageable. Now, if the pathological fracture is such that the tumor tissue is engulfing the neurovascular bundle, then doing an energetic surgery or doing a vascular resection and vascular reconstruction. I mean, we have done those things also, but we should take it with a pinch of salt that we might not really get a good picture, as the case when the vascular bundle was not involved with the tumor. Uh, we surgeons tend to become very heroes, so we should not really be heroic in such kind of major surgeries. We should take the help of our colleagues, some orthopedic surgeon, if possible, another tumor surgeon, junior or a senior person. We should take their help and we should confer failure with them so that we can have a good result. We should have a meticulous plan lined up and we should have a backup plan. We should get a good R0 resection. Now, what is the meaning of R0 resection? When we talk of resection, there are three resections. We call it R0, R1, and R2. R0 is when there is no residual disease left behind, either microscopic or macroscopic, MACRO, macroscopic. R1 is when we feel that there is some kind of a microscopic disease left behind. And R2 resection is a resection in which the gross disease can be seen, that you can see nodules of tumor or some suspicious tissue being left behind. So we should always aim at R0 resection. We should try and get a good neurovascular bundle with good kind of the adventitia covering the vessels and the perineum covering the nerve. You should not be in a way where removing the adventitia and opening up the intima or the media of the vessel so that the vessel can kind of either become aneurysmal or kind of become little lax and it can burst in the postoperative period. We should get good muscle cover around the process and reconstruct. We should use a myocutaneous and free flap if needed, but then generally if you're doing a myocutaneous and a free flap, that means the tumor is a very big tumor. It is kind of got a fungation and those patients need to be kind of monitored very closely. Okay, and my idea is to avoid using of proline mesh and other adjuvants. My reliance is more on biofilm and biology. We have to put large bore drains to avoid collection. Postoperatively, the drains should be kept for a reasonable amount of time so that the collection becomes serious and preferably below 50 to 60 cc before we remove the drains. We have kept drains for as long as about 10, 12 days postoperatively so that collection in the operative bed can be avoided and that can also take care of the infection which could possibly develop because of collection. There should be no tension on the suture line and suture removal should be delayed. The rehabilitation has to be supervised, and we do really get good satisfying functional outcomes despite the large reconstructs that we use. We have seen in all the examples, patient could walk, have good function, no extensor lag, and they are really satisfied and happy. So when we see such large tumors, we should not get discouraged. We should take the help of our colleagues as and when, because there are a lot of orthopedic oncosurgeons throughout the country now. Around 30 years back, there were hardly anybody, but then now there are a lot of people who have done fellowships here and there and then taken training abroad. So we can always confer with them over WhatsApp or some kind of a video call. We can plan the surgery together. Surgeons do travel from one place to another place to do the surgery, and patients can be given good treatment with good functional outcomes despite large lesions. Thank you very much.
Thank you, sir. Thank you for those exceptional cases. The cases were exceptional. Now, all to Dr. Hitesh, sir.
Thanks so much, sir. And I don't know how much time Deepak sir will allow me, but I really want to congratulate you. Some brilliant cases, and you have really summarized it very well, sir. And I was kind of hoping that you would touch upon the resection part, the R0, R1, R2, because that is really a thing that all the audience and especially all the PGs and all the kind of postgraduate students would really learn to we will have a takeaway from this. Just two quick questions, sir. And before that, sir, I'll also kind of commit that even I also, in my practice, rely a lot on biofilms, and I'm averse to this proline mesh and all. So first question is kind of stemming from that. in the lower limbs, definitely, I also feel that biofilm concept works much better. But in upper limbs, sir, what I have really faced a problem with the proximal humerus resections. If we do it without a biofilm, I mean, if we do it without a proline mesh or something, there is a tendency of this the shoulder, the megaprocessor shoulder, to kind of uh, it just goes very loose and kind of transports distally for my cases. So unless and until I've really kind of anchored it well with the proline mesh and tied a whole lot of soft tissue around it, for me, I think it is kind of transporting very distally, which I mean, functionally doesn't affect the patient a lot, but the X-ray looks horrible. So I just wanted your experience on that, sir. That is my first question. And second question would be regarding your first case itself, sir. I don't know whether the physis was involved or not, but if the physis is preserved, what are your comments on Canadell technique, wherein we try to lengthen the physis and increase the so kind of get the margin and you know uh, try to do a more of a joint saving procedure kind of a thing in that case, sir. So just two quick questions, sir.
Yeah. So regarding your first question about use of proline mesh in proximal humerus, now way back in '96 when I was in Tata, I had come with an orthopedic training to Tata, and I was the only orthopedic surgeon in the unit. We had other people in the unit were general surgeons. They were just doing the rotations through the bone soft tissue unit.
Sure.
And the unit was actually breast, bone, and soft tissue. So that was the only unit dedicated to breast work. But breast was being done by all people, but that was the only unit doing breast and bone and soft tissue. So there were two consultants. One was a breast consultant, one was a bone and soft tissue consultant. And I, being a fellow in Tata for 3 years, I was looking at an aspect where I was doing AMRs during my residency, and we designed a very cheap processes, proximal humerus processes, which was costing hardly 5,000 rupees, at that time.
Sure.
But 5,000 rupees was something in the year 1996. It's not really very big amount nowadays, but in the year 96, it was a very big amount.
Sure.
And you would be surprised that we did close to, we would get a proximal humerus and we would always salvage it. We did about 90 cases in a span of 2 years. So initial period was that it was a kind of a fully glazed processes. There was nowhere you could attach that anything, to the processes. It was just like a simple, the AMR had a hole, in fact, at the top.
Sure.
If you remember, the AMP has a hole,
Sure.
in the neck area, in the trochanteric area, but this processor had nothing. So we designed that processes, and then we saw this problem of the processes sinking down. The X-ray was looking horrible, as you rightly pointed out, but the patient was functionally having no compromise.
Sure.
Then the thinking started, so that first few, about 50 processes, 40 processes with no thing. Then we started putting a hole through the processes. So we had hole on the area of the greater tuberosity, and we had a couple of holes in the area of the lesser tuberosity. And that time, Ethibond was not in use, so we were using muscle-in tapes to take a suture through the muscle in the kind of a acromioclavicular joint area, and then we would pass that suture through the hole in the processes in the greater tuberosity area, and then we would take some kind of a labral tissue from the glenoid area,
Sure.
or whatever soft tissue is available medially, and then pass it through the hole in the medial part of the processes. Now those started keeping processes in place.
Sure.
Then we got a little more adventurous. Instead of putting one hole, we started putting 3 holes. And of course, you saw the modern design now, which has got, all through and through things. So
Sure.
it evolved over a period of time. We did use proline mesh of late. I used proline mesh in about 3-4 cases because that idea came from a guy who was doing GI surgery. All these guys were rotating through bone soft tissue. So they rotated from bone soft tissue. Then they go back to doing GI surgery or thoracic surgery, all those senior registrars of Tata Hospital. So then they said कि यार तू proline mesh क्यों नहीं यूज करके देखता है? मैंने कहा हम हड्डियां में करते हैं. So we did a couple of cases. Unfortunately, 2 patients developed some infection and then sinus and all. So I thought maybe, the shoulder being really so this thing, under the skin. So if I can avoid proline mesh, that would be a good thing. And then of course, now, uh, if you see the cases, so each case is different. Now, if you have a good cover on the kind of acromial area, the subacromial area, you can actually do a good reconstruction with the ethibond suture and the holes in the processes. And that keeps the processes in place. Of course, when the tumors are very large and you are taking away the entire soft tissue, then we use Prolene mesh. But then Prolene mesh is something very nice in shoulder joint, but in the lower limb, it's not really a very good thing.
100%
Except
agree,
when
sir.
I'm doing a hemipelvectomy, then I use a mesh plastic, which is kind of very effective to give a good stable hip, you know.
Sure.
So that answers your first question. And the second question was the physis. If you were to see the X-ray of the patient, the distal femoral physis was kind of involved. The MRI of the
Okay.
patient, sorry, not X-ray. The distal femoral physis of that 9-year-old girl was involved. It was not really very suitable for the cannula technique that you're talking about.
Sure.
Then our reasoning happened, our discussion happened that if you are going to resect the distal femoral physis, which is contributing to about 70 or 80% of the the growth in the person, because when you are sacrificing the distal femoral physis, there is nothing you can do to save the proximal tibial physis for the growth to happen.
Agreed, sir.
So if you end up sacrificing the distal femoral physis, you have to sacrifice the proximal tibial
That is
physis.
given, sir. Yeah.
So that is the reason why I designed that joint where I could replace every single part, you know. The head could be replaced, the neck could be lengthened, the trochanteric piece could be kind of changed, the tube of lengthening could be changed, and the distal femoral condyle could also be changed. You know, I could like kind of remove the distal femoral condyle and this thing. So it was a kind of a very differently designed processes. And if you have seen the X-ray carefully, there's no cup to begin with, you know. So
Yes, sir.
we use a 32 head because it was a child. We use a 32 head and because we didn't want to put a 22 head also like we normally put. If we wanted the acetabulum to be full, so that there is no kind of dysplasia of the acetabulum when the child grows. So we took a lot of care for that patient. Patient did really very well for about I would say around 19 months after surgery. And one fine day, due to sudden death syndrome happened to her and she just died, you know, at the end of 19. She did, when we were planning the first lengthening at about 15, 18 months of follow-up, that is the time one fine day she just died, you know. So we could not really go and lengthen and, you know, do all those things. But the processes were designed, and I have the videos of the processes also, where I was showing that I could open it from here and I could open it from there and I could open it from here and kind of, you know, do mix and match and do and everything, you know. So we were very happy to design that, but unfortunately we could not exploit the potential of the design, you know. And
Sure.
then to get another suitable patient where you can kind of replicate the design and you can exploit the potential of the design is this thing. And then of course, as you're a tumor surgeon, you know, there are a lot of things available to you, like the cannula technique. I mean, there are so many things available. And then we are ourselves at a dilemma, you know, what is the best thing we should be doing for the patient?
Sure.
So, you know, I mean, it's a give and take, you know, at the end of the day, something you do and then you always keep wondering, you know, as a true professional, you would always keep wondering, यार ये किया होता तो अच्छा होता, ये नहीं करके ये किया होता तो अच्छा होता.
Brilliant cases,
And
sir. Brilliant
regarding
cases.
your query about R0, R1 and R2, I mean, I thought that when you're talking about surgery, see, Dr. Deepak has been very kind, you know, he's almost given me more than half an hour, I would say now.
Sir.
Sir, it's a very
So
interesting thing.
I normally don't overshoot my time. I try to restrict myself to the time. So R0, R1 and R2 basically I've covered as a part of the talk. I have not shown the diagram, but just remember one thing, that R0 is, you are sure that there is no microscopic and the microscopic disease left behind. In R1, you suspect that you have disease left behind. Like I was doing a resection of a thumb metacarpal. I mean, those are other series which I will show if you permit me at some other time, where we resect the metacarpal and we use a bone marrow graft to do reconstruction with full function of the thumb, you know. So in that, we had a suspicious kind of a lesion looking at the triquetrum bone. So we scraped that lesion and we sent it for histopath. And that came out negative for tumor. Now, had that been positive for tumor, then we could have labeled it R1 because I removed the disease gross wise. But you know, when you're doing the disease in the gross thing, you could really have some kind of cells being left behind. So I could have labeled it R1, but luckily that came negative, so it is R0. And R2 जब भी आपको खुला दिखता है कि disease पीछे पड़ा है, you know. So like the guy who did that nailing for a 30-year-old male patient with chondrosarcoma, that was R2.
R2,
He
for
was
sure.
leaving the disease behind with the nail inside and the disease behind. The disease was growing. I mean, that patient, I have an entire series where I have taken the cut section of the femur. I have shown that how the disease has gone beyond the tip of the nail, and
Sure.
it's also involved the marrow at the, I think about 3-4 centimeters distal to the tip of the nail. The disease has gone because of nailing, and that is why we all keep talking about this thing in the conferences. You know that if you see a long bone fracture and you suspect pathologic fracture, don't rush to operate the patient because you will kind of disseminate the disease inside the
So
body, you know. So
we all call it Whoops lesion, no?
yeah,
Whoops
whoops, yeah,
lesion.
whoops, yeah.
Yeah.
Thank you, sir. Thank you so
Thank
much.
you so much.
Thank you very much.
We can step back to go for the other cases also. If you have any questions at the end, you can be happy to answer them. Now with this, you can unshare the screen, sir. Stop sharing the screen. We'll go for the last arthroplasty session.
I want to thank OrthoTV for giving me this opportunity to show my work and kind of pass on some message. Thank you, Dr. Gautam and your team.
Thank you, sir. It's
And Dr. Anoop.
to have you here in this forum today.
Yeah,
Can you stop sharing it? Okay. So we come to the last part, the arthroplasty case. We have Dr. Srivastava from Lucknow to present the case. He is MBBS from KGMU Lucknow, MS from SN Medical College Agra, and MCS from University of Sussex and American Institute of Medicine. The former fellow of joint replacement at AIIMS New Delhi. Is currently the director and chief consultant at Hamet Hospital, Lucknow, and he's a renowned primary and revision joint replacement surgeon in Lucknow. For this case, we have an expert, Dr. Anoop. He's MBBS from KM, MS from the Maharashtra University of Health Sciences, D Ortho from LTMMC, DNB from LTMMC, and FCFS Ortho from same institute. He's a former assistant professor of orthopedics at LTMC, General Hospital Science. He's an arthroplasty fellow from South Korea and Germany. He's awarded with BIS Junior Fellowship, one of the prestigious British Indian Orthopedic Society Fellowship. In 2018, he has been selected for Ranawat Orthopedic Fellowship at HSS. He has more than 35 publications in peer-reviewed journals, and he's also a reviewer for Indian Journal of Orthopedics, Journal of Orthopedic Case Reports, and ASEAN Journal of Arthroplasty. With this, I would like to invite Dr. Shivendra Srivastava sir to present his case. Make it full screen, sir.
Yeah. It's not coming. Yeah.
There is something coming up, enable editing.
Problem
Cancel that one.
Huh?
You had checked it, it was running well.
I'm doing that.
There is a button at the bottom where we have to go. If you see the bottom,
I think it's not being visible. If there is something
Now
wrong.
it's okay.
Next to the Zoom. Next to the Zoom button on the bottom.
yeah.
Yeah, that's right. Should come down.
Yeah. Is clearly zoom over there?
No, sir.
No.
Is anyone viewing that? You have to go for that slideshow again.
Sorry?
No, sir. It's not full screen. Just go there. Again, you have to click there, sir. Maybe it was double click. Yeah, Now we can.
Okay. It's okay.
Yes, sir.
Yes,
Go ahead.
that's right.
Good evening, everyone. And thanks for Dr. Mohanty and thanks for Dr. Deepak to inviting me on just giving a presentation of one of my case, which I have operated osteoarthritic both knee. And today we'll discuss the thing. Myself, Dr. Shivendra here, orthopedic consultant, orthoplasty consultant, last 10 years practicing in Lucknow. We all have gathered here to listen to brainstorming session of case that we see in our day-to-day practice, everyone almost. Being in a practice, we see patient in pain and discomfort. As it is rightly said, pain is real, but pain is so hope. So, and Hmm, that's what the trust is with which patient comes to us. So similarly, kind of patient I turned up in my clinic. So today I wanted to discuss with you all one of the case. This is a 87-year-old male having a pain and severe varus deformity, as you can see the both knee last 20 years, and known case of diabetes also, and ejection fraction was 40%, and CABG was done 15 years back, and the skin was normal. Bony crepitations was there, both knee, and the varus deformity was right side 20 degree and left side 30 degree, and FFD flexion deformity was right knee 30 degree and left 35 degree, and no neurovascular deficit, nothing was there. So this case I wanted to discuss. This is a pre-op X-ray of the that patient. So just I wanted to discuss panelists. What is the opinion of you guys? What you how we can proceed for this? Anyone?
Yeah, this is one of the good and common cases that we see. So a couple of points that we need to keep in mind is his age. So we need to keep in mind what are the demands of the patient. Secondly, his comorbidities. So whenever we are contemplating over a surgery for a severe varus deformity, we need to equalize the limb lengths. So we'll advise for a bilateral TKR in most of these cases, because that can lead to a limb length discrepancy.
So okay.
The other part, when we are going to have a consensus over the surgery, I usually do a dobutamine stress test. In my practice, for this particular patient with more than one comorbidities, I will not do a bilateral simultaneous in most cases. That's one. If I wish to do it in elderly patient, I'd like to do a dobutamine stress test first, which is going in for most and all of my bilaterals now. In this particular patient, I may stagger it out, just do a unilateral case and then give him a shoe raise on the other side, go in about 3 to 4 months later. But we have to get a bilateral done, because if we don't do it, I think we are doing injustice to our own surgery. It leads to a flexion deformity on the operated side. It leads to a lot of stress on the implant, and it gives bad merit to the surgery itself. Or else we just bite the bullet and it passes the dobutamine stress test and do a bilateral. Some people do it in hospital after about 4 to 5 days, which is what I don't see scientific, because that's the time when the patient is highly compromised from his physiological point of view. And when he's trying to recuperate, we hammer it again. So that's my take. So
I
definitely,
think Dr. Anoop has made a very important point here. Dr. Mrinal, can you join in? Dr. Mrinal there?
Yes.
Yes, sir. So this is a case. I think you must have gone through the clinical.
Yes.
Not uncommon in our part of the country. Dr. Anoop has made one important point. Do you get only echo or DST in all these cases? This dobutamine stress echo in all these cases?
In my hospital setup, we get a dobutamine stress echo for all cases.
All cases.
Knee replacements, yes.
For all cases. Even I was attending a talk there, and one of the surgeons from GRC said, in fact, the routine echo is not much of help for our patients, because we actually want to know what will happen after they start walking. Second important question, which is very burning question in private practice and these doctors. Definitely one after the another. I think all of us will agree. It will be a sequential one, the painful one, the first. What will be the minimum gap between two knees? Dr. Mrinal, I want to know from you.
The minimum gap I usually suggest is 6 weeks, but the ideal is what is recommended is 3 months. It depends upon how many comorbidities the patient has, how much debilitated he is, and how well he recovers within his post-op period.
What is your take on this? Some surgeons doing after 3 days, 4 days, 5 days?
See, I think if you talk about literature, there will be studies on both kinds, sequential, simultaneous, sequential in 3 days and after 6 weeks or 3 months. But I think it puts more stress on the body, even if you do it in the same sitting or after 2-3 days. So ideally, it should be 1 by 1 and minimum 6 weeks should be the interval. Because if the patient is not fit enough to undergo bilateral, he won't be fit in another 2 days. There will be raised parameters like, all those markers will be deranged again. And there are high risks of complications in the next 3 to 4 days, even if you go ahead.
Yes, Dr. Haresh wants to ask a question. Haresh, sir?
Yeah, the question relates to a choice of doing which side, Are we going to cover that, Shiven? Or because if you look at the X-ray on the lateral, the left seems to be reasonably okay, but the right, there is a kind of a posterior slope issue. So
Yeah.
if you have to choose, which one would you choose? That was my question. If you want to look at it as a part of your talk, then it's okay. But if not, then...
Yeah. Yes, they're very important questions. It's very important question. Dr. Shivendra, I know.
Yeah. That's what I'm saying. As we can see, the right one is more deformed, and the problem was more in right side. Patient was having a pain in right side. One thing I wanted to tell you, patient is walking with the help of crutches. As I can show you the picture. You can see the picture. Somehow I cannot add the video of the pre-op, but I have a video with me. When patient is walking full weight bearing on the putting on the shoulder and then just toe touch walk. So probably right side is having a pain. So I went for a right side.
Hold on. What would be the criteria, Dr. Anoop? Is it the deformity, radiological criteria, or the symptomatic pain?
I think symptoms far outdo your X-rays. Okay, so if the patient is symptomatic on the painful side, I would go in first.
Definitely.
Right.
Dr. Meena, I think you will also agree the same.
Yeah, I think this patient should undergo 1 by 1 surgery, and whatever is more painful, you can address that. On the right side, there's a huge bone defect as compared to the left side, which needs to be addressed. You'll need bone grafting. It's covering almost 50% of the medial tibial condyle. So you might also need a stem extender with the augmentation in this case. So that is one point. Number two, this is not a correctable deformity. As I can see, probably it is a stiff varus. You'll need a lot of releases also. And he's 87 post bypass. Always do one at a time.
True.
Next, Dr. Shivendra, go ahead. Okay, Dr. Haresh, sir, yes.
Yeah, I just came. I'm a head of department at Municipal Hospital also here in Mulund.
Yes, sir.
I had a very young enterprising guy who worked with me about 3 years back. He would, in this case, he would say that I would do the left one first. I'm just sharing with his point of view, which I found very logical. He said that I would do the left one first because left one is least damaged compared to the right side. The results will be good and patient will have no lead time delay for the second surgery. If I do the right side first, sir, he was telling me that if I do the right side first, sir, and if there is a setback, then I'm not going to be able to operate the left side, So that is just something which has happened with us about this. We had a similar kind of a case about 3 years back, and that guy was so clear that he wants to do the left side first and not the right side first because left side is relatively better need to operate. A good result will anyway come. Patient will be happy. And I don't want any technical things to delay the second surgery. So I don't know if that is practical or no, but I just thought I would share that opinion with you and just kind of, add something on the table to that.
Dr. Anoop, you were an assistant professor previously in one of the municipal hospitals. Now, what would be your take?
Yeah, I think
also something, from his point of view.
That's right. So overall in our practice, the best result or outcomes or prompts are in patients with the worst knees. I think we see
Yes.
that quite commonly in patients. I think that is the first take home. The borderline cases that are operated for TKRs for an extended indication are the worst PROMs. So I think from the logical point of view, the worse the knee, the better the outcome. I think that's one thing that we have seen all across the PROMs across the world. Secondly, saying that we'll assume that something goes wrong in the worst knee, I think that is not acceptable. I think you should take help, get the justice done to the patients, delivered on the table, because that's what the patient has come in for. So he says that my right leg is more painful. I can still take some weight on the left side. So we want to make him walk with relatively less support. I think that is the target of the surgery. I think that following that dictum, I think do it right the first time. Assume the defects. Get a stress views done. You have a large defect. You need a good release. You would keep some constrained implants on table. So all these things is what we would preempt initially. I think that is what we need to tell them. Maybe and any which way, doing bilateral and heroics is not recommended in these particular patients because the kind of concentration and time that you spend doing one, you lose out while doing the second. So I think that's what my take is.
Yes,
Can
Dr.
I add something?
Yes,
So
sir.
if you see this patient's X-rays on the lateral views, both sides, you will see some craters form. So that crater is the defect. It is almost equal on both sides, but the right side is more posterior medial, so you can't see the posterior border as well. Whereas on the left side, you can see the whole of the crater like a cup, like a saucer. You can delineate that on X-rays also. So both these would be, I think, having bone defects, major ones which will need reconstruction. It's the patient's choice. If he says, my left is painful, you do that one first. But it will be almost similar approach on both sides. I have written a chapter in my book on knee arthroplasty on this, and I have also published my outcomes of 55 cases with bone defects in 2013 in Indian Journal of Orthopaedics. So all of these would be stiff knees, lot of releases, bone defects, both sides, needs augments, and even sometimes I've even used mesh. I've used impaction bone grafting with stem extenders, and the wire mesh has to be used, which comes from Stryker, and you have to fix it with screws. So those
The
can be
technical
such
part-
big defects.
Hold on. The technical part we'll still be discussing. Dr. Haresh's point was that some of them recommend the easier knee first, but the message is clear. Dr. Anoop has told it clear and loud that the more symptomatic knee, more justice to the patient. Am I right?
Yes.
Yeah.
Okay. Go ahead, Dr. Shivendra.
Yeah, so as we all discuss the same challenges in front of me, age is a big challenge. Deformity, as we all can see, the things are more deformed, and the comorbidity, the choice of unilateral or bilateral in single sitting, what we have to do. So these are the point, and choice of implant is a big choice also. So I just put the backup of the implants also, constrained knee and all I kept with me. So finally, right knee was more painful. Patient complaint was, so finally I went for the right knee, and I did it. Right knee first I did it, and as you can see, a lot of soft tissue dissection was there. So in between, and put the bone graft, as you can see the mark over there. I put the take the tibial graft and taking as a bone graft, and put the screw and make a platform for the tibial base plate, and putting the thing. And now right knee first, and then after 4 months I did the left one. So the patient was after post-op, you can see the patient straightening of the leg and all. The patient is walking well. And this case was I operated in 2020, and now the patient regularly, he's far away from this place, and I've requested a thing for the video of the walking also, but right now I'm not having with me. So this is all I done. So
Can you go back to the X-rays? Go
Yeah.
back. Go back.
yeah.
Any comment, Dr. Anoop?
Yeah. So basically, that's right. So we need either an augment or a bone graft to supplement your tibial base plate, considering 50% of your condylar loss on the tibia. So he's used an extender. On the femoral side, the sequence of releases will be either first we do our conventional bone cut with an MA of 0 if it's done conventionally. For the defect is what we would manage with a stem and an extender. Then we do a good peel on the posteromedial side. Now, the question that I wish to ask is whether he has, I think he has intentionally or unintentionally, the medial epicondylar slide has somewhat happened there. And that's a part of the release, or while putting in the trial, it has slipped off.
Yeah. Yeah. On the, as we can see on the right side, there is a, while releasing the soft tissue, there was a avulsion of the bone at that time. So that's why I put it a screw on the femoral medial condyle side.
Right. So this is what happens usually when we don't do pie crusting, because pie crusting is what most people don't do, fearing the MCL being incompetent. But then I think that is a very good tool if you do a controlled pie crusting, because that's the last step in your release now. When in spite of the osteophytes removal, good posteromedial peel,
Right.
you lateralize the tibia, lateralize and downsize the tibia. In spite of doing all that, what is left in your hands is either a cheat cut on the medial side to get that tight medial compartment released, or if you're using a stem and you can't go beyond a certain limit conventionally, you will try to do a pie crusting of the MCL so that it opens up a little. If that is not done, it just pulls off the epicondyle. In fact, you're lucky that you could fix it back. In these particular patients, when you have an on-table epicondylar being avulsed, I would have done a CCK or a constrained condylar implant, having known that it has happened on table, rather than relying on the stability.
On the backup, I kept all the implant over there.
Right. So I mean, I would have just increased the CCK, the VVC poly, and finished the piece up.
Yeah.
Mrinal?
He's done the case pretty well, and he has lateralized the tibia, he has built up the bone defect, he has also balanced the knee well. The only thing I would have done differently would have been probably I would not have done the pie crusting. So even after all the posterior medial releases and the lateralization and the reduction osteotomy, if I'm not able to correct the varus and still the deformity is there, I would have straightforward gone in for the epicondylar osteotomy.
Right, slide osteotomy.
So he did not do it, the nature did it. So actually that is what has happened, and it has balanced it, and he had to fix it because it got avulsed. So if we, especially in osteoporotic bones, it is a very common occurrence, but you can fix it with screws. But in a very severe, whereas 20-25 degrees, if you're not able to get a reduction, despite all releases, instead of doing a pie crusting, go for the epicondylar osteotomy, and you'll get a much better, balancing with those without using need to use a constrained implant in such situations. So I think that that's what I would like to convey.
I think he did the right one first. The patient must have been happy, so that he came for the left side. One. Second, you can see in the last photograph also, the right side it was almost stayed without any brace. So you must be doing well. We hope the patient.
Yes,
maybe sometimes in the future when you present such case, the similar case somewhere, you may get the video of the patient. With this, we'd like to come to the end. Well, almost 30 minutes more than. Okay, Dr. Haresh, sir. Yes, sir.
If you permit me, I can ask all the experts in the panel 2 questions. Okay, one is, how much do you rely on doing a scanogram when you're doing a knee replacement to calculate your angles and other things? And second question is, when you're having such senior citizens with weak bones, do you consider giving post-operative supplements to supplement the osteoporosis? Like you want to give teriparatide or denosumab or bisphosphonates? What is your experience with both the things?
My answer is,
all of you can share your experience.
My answer is yes and yes for both of the questions. Okay.
Yeah, sir. I would like to go for the scanogram, but when I actually in my city that was not available at that time. The reason behind this, because I used to go the scanogram. And the second, I always prefer anybody, any senior citizen, if I operated, I used to start the osteoporotic treatment like teriparatide and denosumab. A lot of things are there. So accordingly.
Dr. Anoop?
Yes, yes for both.
Right.
In some places where we can't do a scanogram, for most patients, we do a scanogram. If in some places where it's not available, we do not do it. But I would insist on a patients which are very, very short and obese and very tall. I think those particular subsets we may, or any kind of obese deformities, especially extra-articular, we would do a scan. Otherwise, it's pretty much yes.
If it's not available, at least you can get a pelvis AP view. Those are you can see the neck, whether it is
Yes, yes.
and valgus angle you have to be.
Yeah, and if at all we can't get a scanogram done, but at least we do a full length femur, EP and lateral. I think the problem comes with the femur, tibia, we can still, it's a subcutaneous bone.
Yeah, that is exactly what I was trying to hint at, that there could be an excessive bow in the femur.
Yes.
And if you're using the TCAR with a conventional technique of intramedullary rod, the juniors might find it sometimes challenging, you know, to the femur is bowed. You know.
Definitely, sir. Definitely. Actually, the X-ray should be complete. It will aid on that. Definitely. Okay, with this, we'll have come to an end for today's session. It was quite interesting, all challenging cases, interesting cases. Thank you all. Thank you all the speakers and the expert panel in this forum today. We'll be back again after 2 weeks, same time, Wednesday evening 8 to 9 p.m. I would like to thank to OrthoTV and my team who are there in Serbia there. They can see this in YouTube where in the evening. I think they are 2 hours behind us, right? If I'm not wrong. Thank you all. With this will come to an end. Good evening to you all.
Okay, thank you
so much.
Thank you, everybody.
Thank you so much. Thank you so much. Bye-bye.